Today we're going to be discussing kidney transplants. We shall cover in this episode evaluation of kidney transplant in donors and recipients. We shall see the complication of renal allografts, and we shall be looking at rejection. Before we begin, please like, share, subscribe, and put on notification to receive all our free lectures. For more information about our paid classes, please send an email to SonoEyesDiagnostics@gmail.com or WhatsApp me at +234 9019 144 175 or visit our online store at sonoeyes.business.site. Attempt the quiz in the description and leave me a comment. Welcome back. Now, ultrasound plays important role in the initial and long-term follow-up of renal transplant. Allograft refers to any tissue transplant from one human to another. Therefore, a transplanted kidney is also known as renal allograft. In abbreviation, you have the TX. Let's look at surgical techniques first. Renal allograft is usually placed in the iliac fossa between the peritoneum and the iliacus muscle. This is the retroperitoneal or extraperitoneal in location. It may be placed intraperitoneally if it's too big for the usual extraperitoneal location. A right donor kidney is usually turned over so that the renal pelvis and ureter are usually in position anteriorly to permit easier access if later intervention is required, and placed in the recipient's left iliac fossa. Similarly, a left donor kidney is placed in the right iliac fossa. The allograft ureter is passed through an oblique tunnel in the muscle layer of the bladder, forming a non-refluxing uterovesical junction. Now, this image gives you an idea of the placement of the renal allograft, the transplanted kidney, around in the iliac fossa. The transplanted renal artery may be attached in one of three ways. The end of the allograft artery is attached to the side of the iliac artery. This is the most preferred method because of lower incidence of post-operative stenosis, and you see the image as the attachment is done. The end of the allograft artery is attached to the end of the internal iliac artery, just as you see in this image. The allograft artery attached to the native iliac artery. And there is the Carrel patch attachment. Cadaver kidneys are commonly removed with a portion of the aorta. So the aorta is sutured end to side to the external iliac artery. Multiple renal transplant arteries require additional anastomosis. The transplanted renal vein is usually connected end to side to the external iliac vein, like you see in this drawing. Now, the native kidney in all cases are left in place unless they are associated with complications like infection, post-dialysis, acquired cysts with risk of development of neoplasm. Now, renal allograft scanning protocol. Now, the transplanted kidney is usually located superficially. Therefore, a 5 to 7 MHz linear or curve array transducer may be used, which provides a good near field and a broad field of view. A baseline scan is performed within the first 24 to 48 hours following surgery. Now, this provides a frame of reference against which all future scans will be compared. A second scan can be performed 1 to 2 weeks post-transplant and the third scan about 3 months. But you already have a baseline where you compare your sonographic findings, features to draw a diagnosis and condition of the allograft. The scan of renal allograft are usually done with full bladder, which helps to displace the overlying bowel from the transplant. The transplanted kidney is scanned both sagittal and transversely. Maximum length, width, and AP measurements are taken, and the renal volume is calculated. An increase in size of the transplant is best appreciated through volume measurement, which is an important feature of allograft pathology. The echogenicity of the renal cortex, medulla, and the renal sinus is evaluated, and if it is a follow-up scan, you compare to the baseline and the previous scan. The perirenal areas are scanned for possible complications like fluid collections, masses, hematomas, lymphoadenopathy, and so on. Slight dilatation of the renal pelvis is common and normal. However, dilatation of the calyces is a reliable sign of obstruction, so you want to pay attention. Now, if hydronephrosis is present, the bladder should be emptied and re-examined to see if dilatation is secondary to the bladder distension. Doppler study is essential for evaluation of patency of allograft artery and veins. Color Doppler, spectral Doppler of the upper, mid, and lower pole of the intrarenal artery are obtained, and the RI is calculated. Pulse Doppler provide evaluation of vascular perfusion of the allograft and is used for detecting focal flow disturbances. In ultrasound, a transplanted kidney looks like a normal kidney with the following variations. Echogenicity of the cortex is equal or slightly greater than the medullary echogenicity. Absence of cortical medullary differentiation is often normal in many transplant kidneys. Echogenicity of the cortex and medulla is uniform throughout the kidney. Area of focal increase or decrease will suggest pathology. Now, renal size, the volume of the normal renal transplant kidney may increase in the first 2 to 3 weeks after surgery by as much as 20%. Normal kidney in transverse scan is elliptical in shape with the width greater than the AP dimension. Rounding of the kidney with the AP dimension equal to the transverse dimension is a sign of diffuse renal swelling and enlargement. When you have a mild pelviectasis, is common and normal. However, hydronephrosis may be due to obstruction or edema at the uterovesical anastomosis site. Now we have these images you see on the screen of normal anatomy of the transplant kidney on sagittal grayscale, and we have the color Doppler and power Doppler images, which will show the homogeneity of the homogeneous vascularity of the entire normal allograft. Then you have this duplex color Doppler analysis. Now, complications of the renal allograft. Acute or immediate complications could be post-operative fluid collection, vascular complication, functional complication. Now, post-operative fluid collection will include hematomas, abscess, urinoma, seroma, hydronephrosis in renal allograft. Vascular complications will include renal artery stenosis, renal vein thrombosis, segmental infarction, and AV fistula. Functional complications would include acute tubular necrosis, cyclosporine nephrotoxicity, and acute rejection. With respect to chronic or late complications, you could have chronic rejection, lymphocyl, stone formation and obstructive uropathy, AV fistula, arteriovenous fistula, pseudoaneurysm, lymphoma. Let's look at these complications one after the other. In post-operative fluid collection, these fluid collections in and around the transplant kidney is very common in the immediate post-operative period. About 40% of transplants, you find that. Large fluid collection can compress and compromise the transplant, whereas smaller ones often resolve spontaneously without affecting the transplant kidney. The clinical signs and symptoms include pain, swelling, tenderness, fever with respect to infection and abscess, oliguria, anuria, and in that case you will see urinoma on ultrasound. Ultrasound appearance alone is sometimes not enough to differentiate types of collection. So you may see collection, and you want to go further and find out what type of collection is there. So ultrasound guided aspiration and fluid analysis is sometimes required to actually differentiate what type of collection is there. So differential diagnosis for this post-operative fluid collection will include hematoma, abscess, urinoma, and seroma may occur immediately after transplant, about 24 hours to 2 weeks. Lymphoma may develop between 2 to 6 months post-operatively. Hematomas usually occur in the immediate post-operative period, associated with pain, tenderness over the transplant kidney or in the wound, and there is drop in hematocrit and hemoglobin values. An increase in size of the hematoma or drop in the hematocrit value indicates continuous bleeding, and there will be need for intervention. On ultrasound, the sonographic appearance varies with the age of the hematoma. Acute hematoma looks anechoic and then echogenic in 24 to 72 hours. Thereafter, it will look mixed echogenic, usually about 14 days forward. Old hematomas are given again hypoechoic or anechoic. That will still depend on the age of the hematoma. In abscess formation usually it occurs in the immediate postoperative period within 1 to 3 weeks of transplantation, when wound infection develop or there is this pre-existing fluid collection that became infected. So clinical signs and symptoms include pain, tenderness, high fever with leukocytosis. These are usual signs. However, due to immunosuppressive agents, this may be minimal. But on ultrasound, an abscess usually appears as a complex cystic fluid collection with mixed echogenicity. And there may be internal echo or debris, fluid debris level septations. These are the characteristics that may apply to abscess on ultrasound. Abscess may be within the renal parenchyma or in the wound, or maybe perinephric. Now, with respect to urinoma, this is caused by a leak in the urinary system, either from the faulty surgery or an over-distended bladder causing reflux and will require immediate surgical correction. This will occur within the first and second week after transplant. The signs and symptoms here will be the patient will be experiencing sudden oliguria or decrease in urine output, along with pain and tenderness. On ultrasound, anechoic fluid collection, which is free if it's immediately after the operation, or will be walled off after a few days, usually near the lower pole of the transplant, and may show septations. Large fluid collection may compress the transplant and may cause hydronephrosis. That is the dilated pelvic calyceal system. With respect to seroma, it is a localized collection of serum fluid in a tissue or organ. Usually it accumulates adjacent to the transplant kidney or in wound. Usually it's small, asymptomatic, and appear usually early post-operative period, and it will regress spontaneously in days or weeks. Large fluid collection may require percussion, aspiration, drainage. On ultrasound, typically is anechoic. You see this anechoic serous fluid collection. With respect to lymphocyte, is most common fluid collection that is seen on transplant, and that is after transplant. It occurs after 2 to 6 months post-operatively, caused by leakage of lymphatic channels when preparing the patient iliac fossa for transplant surgery. Transected lymphatic vessels channel usually re-anastomose within 2 or 3 weeks. Fluid collection is medially between the lower pole of the transplant kidney and the bladder. Is basically the location where you see such fluid collection. A lymphocyte may cause compression on the adjacent structure, commonly the graft ureter, causing hydronephrosis, or iliac vein hydronephrosis or compression on the iliac vein will lead to swelling of the leg. If no obstruction is associated, lymphocyte is usually reabsorbed spontaneously. Otherwise, they may be drained into the peritoneal cavity to enhance absorption, or may need external percutaneous drainage. However, external aspiration is not always effective, as fluid may recollect within 24 hours. On ultrasound, it will appear as a well-defined anechoic fluid collection with or without septation. Difficulty to differentiate from urinoma sonographically, but sometimes the appearance and patient presentation are diagnostic for urinoma. Hydronephrosis in transplant kidney. A minimal degree of hydronephrosis in allograft is common during the first week or 2 weeks post-operatively. Now, due to the post-operative edema at the insertion site of the ureter into the bladder or the temporary impaired ureter anastomosis. Overhydration or over-distended bladder may also cause transient hydronephrosis that resolves after voiding. In some cases, mild hydronephrosis may persist for indefinite period, but of no clinical significance as long as the urine output is good. Renal function also should be satisfactory. Clinically or functionally, significant hydronephrosis are usually results from immediate or late post-operative complication causing obstruction, commonly ureteric obstruction. Common causes of hydronephrosis and allograft are ureteral necrosis at the resection site, torsion, stricture at the UVJ, the uterovesical junction, blood clot, stone formation, and extrinsic compression by perirenal fluid collection like hematoma, abscess, urinoma, lymphocyte, and so on. Bladder emptying disorder and vesicoureteric reflux may also cause hydronephrosis of the renal allograft. Functional complication of renal allograft. A reduced transplant kidney function is associated with raised serum creatinine or reduced GFR. Common causes are acute or chronic rejection, acute tubular necrosis, cyclosporine nephrotoxicity, urine obstruction caused by pathologic fluid collection, hematoma, abscess, urinoma, lymphocyte, and vascular complications. Ultrasound and ultrasound-guided core biopsy are required for definitive diagnosis with respect to functional complication in allograft. Sonographic features in the reduced function of renal allograft. The transplant kidney enlargement will be, you see the AP diameter is equal to or it exceeds the transverse diameter. Cortical thickness will increase. The volume increase of about greater than 25% is considered abnormal. Renal cortex may have increased or decreased cortical echoes. Corticomedullary differentiation may be lost. Pyramids, the medullary pyramids may become more prominent. Renal sinuses, echogenicity may be absent. The collecting walls may be thickened. In acute tubular necrosis, there is an acute renal shutdown due to abrupt lowering of blood pressure and resulting in ischemia. It is suspected when the transplant kidney shows poor renal function in immediate post-transplant period. It is usually self-limiting. Supportive treatment is required until renal function returns to normal. Ultrasound cannot differentiate acute tubular necrosis from acute rejection, so you require a biopsy for confirmation. Cyclosporine is used to prevent rejection, but high doses can cause nephrotoxicity and renal failure. Function often will return to normal with a reduction of the dose. Renal biopsy also will be required for a definitive diagnosis. Now, transplant rejection. Allograft rejection occurs as a result of the immune response. Fever, graft tenderness, and oliguria are hallmarks of this rejection. However, these features of rejection are modified or may be masked by cyclosporine or immunosuppressive agents therapy. Renal biopsy is usually required for definitive diagnosis. Graft rejection can be classified into 4 types: the hyperacute rejection, accelerated acute rejection, chronic rejection. Hyperacute rejection occurs during the surgery. Accelerated acute rejection occurs within 2 to 3 days after surgery. Acute rejection occurs within 1 to 10 weeks, and chronic rejection occurs months to years after the transplant. So let's look at acute transplant rejection. The signs and symptoms occur as early as 1 week to 10 weeks post transplant. There is decreased urine output, fever, graft tenderness, and hypertension are actually the hallmark of this rejection. Lab data will show increased creatinine, BUN, decreased perfusion uptake in the NM scan, nuclear medicine scan. On ultrasound, the transplant kidney is enlarged. So an increase in size and volume is what you would notice. There will be diffuse increase in cortical echogenicity with prominent enlarged medullary pyramids. You'll see the prominence of the collecting system. And there's also going to be increased arterial resistance with Doppler resistive index of 0.75. Chronic transplant rejection signs and symptoms occurs after months to several years of transplant. Lab data will show increased creatinine, BUN, electrolytes. On ultrasound, in early rejection, there is normal or overall enlargement of the kidney with diffuse cortical echogenicity and loss of corticomedullary differentiation. Late chronic rejection, the allograft kidney becomes small, shrunken with a highly echogenic and thinned cortex with complete loss of corticomedullary differentiation. The loss of differentiation between the renal parenchyma and the renal sinus may occur. Mild hydronephrosis may be present. So you could also have loss of renal function progresses to complete renal failure. The role of ultrasound in allograft complication and rejection. You see, ultrasound is not sensitive in diagnosis of allograft rejection. As allograft rejection, acute tubular necrosis, cyclosporine nephrotoxicity are all of them gives similar ultrasound features. Definitive diagnosis of these conditions, especially that of the rejection, is best made by renal allograft biopsy. Here you have an image of acute rejection, chronic rejection, and what you would see on ultrasound. Now, a quick look at the Doppler assessment of transplant kidney. Doppler assessment of transplant kidney include color Doppler, pulse wave Doppler assessment of the main renal artery, segmental and the interlobar artery of the upper, mid, and lower pole of the renal vein. Pulse Doppler can be used to evaluate overall transplant perfusion. Doppler assessment of transplant kidney is easier than that of the native, as it is much more superficial and higher frequency can be used. The external iliac artery, most commonly the main renal artery is connected to, uses the end-to-side anastomosis. So in pulse wave Doppler, the normal external iliac artery will display characteristics of triphasic high resistance wavelength. The transplanted main renal artery can easily be identified using color Doppler arising from the anastomosis at the external iliac artery and crossing anterior towards the renal hilum. It should be carefully examined for evidence of narrowing or leakages. With pulse wave Doppler, the normal main renal artery displays a diphasic low resistance arterial waveform with ROI value of less than or equal to 0.7. If a parvus status waveform is seen in the main renal artery, it indicates a proximal hemodynamically significant stenosis. In this case, the anastomosis should be evaluated by color Doppler and pulse wave Doppler. If a triphasic high resistance waveform is seen in the main renal artery, it suggests a problem downstream that is causing the increased resistance to the flow. In intrarenal vessels, the segmental and interlobar arteries in the upper, mid, and lower poles of the transplant kidney are assessed. Pulse wave Doppler waveform from the vessels normally will display diphasic low resistance flow pattern, same as you have in the main renal artery. A parvus status waveform is suspicious of significant proximal stenosis. An abnormally high resistance waveform is an indicator of a problem downstream that is causing increased resistance to flow. Example will be acute rejection. In renal perfusion, overall renal perfusion of the transplant kidney can be assessed by color Doppler, power Doppler. Power Doppler is better for this due to its increase in sensitivity for detecting flow from tiny vessels. The upper, mid, and lower portion of the transplant kidney should be assessed to ensure there is good perfusion to all the region of the renal parenchyma. A segmental or lobal defect in perfusion is suspicious for a segmental and or lobal infarct. Renal vein. Using color Doppler, the renal vein should also be seen leaving the renal hilum and running posteriorly towards the external iliac vein. The renal vein should be widely patent. The pulse wave Doppler waveform typically displays a low velocity monophasic wave like any other peripheral vein. Vascular complications of the renal allograft. The vascular complications that can occur includes renal artery stenosis, renal vein thrombosis, lobal or segmental infarction. I want to thank you for joining this lecture today. Please like, share, subscribe, and put on notification to receive all our free lectures. For more information about our paid classes or to support our free lectures online, please send us an email at SonoEyesDiagnostics@gmail.com or WhatsApp me at +234 9019 144175 or visit our online store at sonoeyes.business.site. Attend the quiz in the description and leave me a comment. Until the next time when I come your way again, keep learning ultrasound.